Okay, good evening, everyone. My name is Edith Schussler. I'm an assistant professor at Cornell in Allergy and Immunology, and I have the pleasure tonight of introducing Dr. Monica Lawrence and Dr. Henry Tazelaar, excuse me. Monica will be presenting a case on the evaluation and management of lung disease and primary immunodeficiency. Monica is an assistant professor of medicine and pediatrics at the University of Virginia. She's also the fellowship training program director there. She completed her medical degree and residency in internal medicine at Washington University Barnes-Jewish Hospital in St. Louis, and her fellowship at the National Institute of Allergy and Infectious Diseases. And she, as I said, is currently an assistant professor of medicine and pediatrics at University of Virginia. And then we have a really great pathologist who we don't usually have pathology readily available to us, which will be great. Dr. Henry Tazelaar is currently the Geraldine Colby Seiler Professor of Cytopathology in the Mayo Clinic School of Medicine and Science and Chair of the Laboratory Medicine and Pathology at Mayo Clinic, Arizona. He received his MD at Rush University Medical Center and then completed residency and fellowship in surgical pathology and cardiopulmonary transplant pathology at Stanford University Medical Center. He's been on staff of Mayo Clinic since 1988. And his research interests include the pathology of heart and lung transplantation, neoplastic and non-neoplastic heart and lung pathology, and pleural disease. He has a particular interest in the pathology of granulomatous lung disease and lung involvement in systemic disease, and he's the author of over 300 peer-reviewed publications. So I'd like to welcome you both, as well as all the attendees. And Monica, I'm going to leave it to you.
All right, thanks, Edith. I can't resist the opportunity for a good pun. The kind of title of my talk is All That Glitters GLILD. And so I'm going to present to you a case from the clinic of a 49-year-old patient I met a few years back who came in to the immunodeficiency clinic reporting a history of pneumonia once every year for about 6 years running. All of them were symptomatic with cough and fever. 2 of them were chest x-ray confirmed, and the rest were clinically diagnosed. And all were treated with antibiotics and resolved in an appropriate time period with outpatient management. Other than that, she's been relatively healthy. So just some bronchitis and cough a few times a year, and then some warts on her hand. So really a very unimpressive infectious history other than the pneumonia. As a child, she said she had recurrent otitis media and recurrent strep pharyngitis, but those both resolved after having her tonsils removed and getting tympanostomy tubes placed. Past medical history was notable only for allergic rhinitis, which she treated with Flonase and Zyrtec. Her family history was negative for consanguinity, no autoimmunity, no history of immune deficiency, leukemia, or unexplained childhood deaths. For social history, she runs one of the best steakhouses in town. She doesn't have any pets. She's not a smoker and isn't around any smokers. On her physical exam, it was truly unremarkable. No adenopathy, no hepatosplenomegaly, importantly. And on her initial blood work, her CBC with differential had a normal H&H, normal platelets, normal ALC and ANC. And her metabolic panel only showed a really slightly low total protein with a preserved albumin. So I decided her convincing history of pneumonia was enough to pursue some further workup, and so we did some basic labs showing agamma-globulinemia, so undetectable G, A, M, and E. She also had nearly absent isohemagglutinins with an anti-B titer of only 1:1, undetectable titers despite being vaccinated to tetanus and diphtheria and MMR, and having clinical varicella as a child. Her SPEP showed no clonal peaks. Her kappa and lambda-free light chains were undetectable, and on flow, although she had normal TB and NK subsets, she had a marked decrease in class-switched memory B cells and plasmablasts. Here. So it's normally, for us, we get baseline lung function testing and high-resolution CT tests on our patients with newly diagnosed agamma-globulinemia or CVID. So we did that for her. And in her case, and remember, she had absolutely no respiratory symptoms when I first met her, despite this recurrent pneumonia and despite the bronchitis. In between episodes, she's completely well. So we had normal FEV1 to FVC ratio, normal FEV1 and FVC, normal lung volumes, and essentially a normal, was reported as a normal diffusing capacity, although it's sort of getting towards the lower limit of normal. And on high resolution CT of her chest, they noted some diffuse mild mediastinal lymphadenopathy, some peribronchovascular fissural nodules with some mild interlobular septal thickening, as well as bronchiectasis, and some kind of modest splenomegaly that you can see on the CT abdomen. So to summarize, we have a 49-year-old lady, recurrent bronchitis and pneumonia, agamma-globulinemia with impaired B-cell maturation, normal lung function testing, essentially, although I could argue that the diffusing capacity is abnormal, while not technically by ETS criteria. She had mild lymphadenopathy, some lung nodules and mild bronchiectasis, and some mild splenomegaly, but without any cytopenias. So I guess I'll stop there and let Edith maybe do some discussion.
Yes, so first for the attendees, there is an attendee chat. So if anyone wants to send in their questions or has any points they'd like to bring up at this point. But I would say at this point, you know, obviously or not obviously, but we're looking at an antibody deficiency and with lung pathology. And the discussion point of what we would do next, I think, is a very good one. And just, you know, thinking about the differential, but also what next steps would be important in looking at that lymphadenopathy and the lung nodules. Any thoughts? Anybody in the audience want to break in here? Or maybe Monica, I'll come back to you in terms of looking at this as your patient, where you would think or what you were thinking about doing next, especially with the lung nodules and bronchiectasis.
Yeah, so while I'm waiting for anyone else in the audience to chime in, you know, my debate here at this point is that we have a lady who has no symptoms and has normal lung function testing, but has some mild radiographic changes. So I'm worried based on her low switch memory B cells, and I'm worried based on her radiograph, but I'm not that worried because of her lack of symptoms and her normal PFT. So the question is, at this point, how aggressive are you in working her up? Do you push for bronchoscopies? Do you push for biopsy? Do you go ahead and treat? So that is what I guess we want audience input, and then I can tell you what I did. But
okay, and we do have a couple of suggestions from the audience. So one is asking about induced sputum in this patient. Was that? thought about or done?
So that was not done at that time, but it was done later.
Okay. And then a question about whether or not there was a CVID gene panel, or at least thinking about looking for TACI.
Yep, totally agree. Done later, but at that time I didn't send it.
Okay, and then at this point we are getting to the actual lung, and there's a question about biopsying the nodules.
I think I can talk now. Can anyone hear me?
Yes.
Yep.
Oh, good. I'm Jack Rudis. I have a couple thoughts on this. The first is there are good studies now to show that pulmonary function tests are insensitive in picking up significant parenchymal lung disease, including GLILD. So having a normal set of pulmonary function wouldn't really, if it was bad, it might influence me, but being normal wouldn't influence me one way or another. And then the second point I want to make is GLILD really has a very distinctive radiographic look by CT scan. It's not a few nodules that are diffuse. These are predominantly what will catch your eye is it's a macronodular disease. There are tons of small nodules, but unlike sarcoid, in GLILD you get large nodules. And for whatever reason, I have no idea why, in every single case that we've seen, they're always in the lower lung zones. So you see multiple large nodules admixed with small nodular disease in the lower lung zones with diffuse mediastinal adenopathy, typically with splenomegaly and other adenopathy throughout. So I don't know how bad the nodular disease was, but that certainly would influence what I would do immediately.
It was very mild, so I'll go back and show the radiograph again. That was probably the worst of the cuts, but the majority of the lung fields were clear.
Yeah, I couldn't get online for some reason, so I can only hear. But if it's mild, that definitely would. I think some of the confusion in the literature and reading, some of the papers that have been out, are, when you see a few nodules feeling like you have to just biopsy them. Sometimes small nodules in a new diagnosis of CVID are just inflammatory nodules, and some of those will go away with treatment. Others, where they're just a few scattered nodules, because the CT scan is so good nowadays, typically what we do is just if the patient has any suspicion of infection, we'll go ahead and get a BAL. Probably not a transbronchial biopsy, but depending on how bad the bronchiectasis is or some other features on the CT scan, we might. And we would just follow this patient expectantly.
Okay. Well, that makes me feel better because that's what I did. So, Edith, are you okay if I keep going?
Yes,
or do you want...
absolutely.
Yeah?
No, that's absolutely.
Okay, so I went ahead and started on IVIG with a plan to transition her to sub-Q eventually. We offered her an open lung biopsy up front, but she declined, so we went and did a bronchoscopy with a BAL. And we did actually do a transbronchial biopsy at the time. That showed the gross inspection of the areas was normal. The BAL had a normal cytology. Cultures were sent for bacteria, fungus, and AFP, and those all were negative. So going back to kind of the induced sputum question. The transbronchial biopsy just showed chronic inflammation. And then the flow was mostly alveolar macrophages, and then there's 21% CD3 positive T cells with the CD8 predominance, and then 2% B cells. And so at that time, I chose to follow her expectantly and did not do anything further other than start treatment with IVIG.
correct me if I'm wrong, Dr. Roots, but when you look at that CD4, CD8 ratio, that's also one of the things that differentiates from sarcoidosis, correct?
It does, but so yeah, typically in sarcoidosis, it's a CD4-driven disease. So you can even see peripheral CD4 lymphopenia when the sarcoid is pretty bad. In GLILD, when we reported 16 consecutive biopsies, in general it's CD4 more than CD8s, but there have been a few cases over the period of time where we've seen CD8 more than CD4. So it's not as hard and fast as sarcoidosis.
Got it.
Okay, so I started her on IVIG and brought her back, and a year later on her return checkup. At this point, she says that she's getting a little bit of mild dyspnea and exertion, but no symptoms at rest. Of course, she also says that she spends more time in the kitchen running her steakhouse than exercising, so it was hard to really know if that was deconditioning or lung disease. Her IVIG was going well. Her IgG trough was a little bit lower than I wanted, but she wasn't really having infections, so it was at 666. At this point, though, her labs had started to look abnormal, so her white count fell down to 2.4. Her hemoglobin was slightly lower at 11.2. Her platelets were markedly lower at 37, but her ANC and ALC were preserved. Her metabolic panel now showed some slight liver enzyme elevation with an ALT of 69 and an AST of 73, and her inflammatory markers, her CRP was now elevated at 3.5.
What was her phos and gamma GGT, or either of those?
Those were both normal.
And this was her first bout of thrombocytopenia?
Right. Well, I'd only met her for a year, and so I had CDC2 or so CBCs, and those were both normal previously, and then this was the first time I noticed thrombocytopenia. So because
I have one more question that came in on the previous slides, which was, does the 2% CD19 in the lung biopsy mean anything? And what about LDH? So I'd start with the CD19.
I'll have to ask Dr. Tazelaar or Dr. Rudis to weigh in on that. I just took it to mean that there were B cells and that I needed to, if I was going to treat, I would need to target them.
This is Tazelaar. Good evening, everybody. I don't know enough to know what that means.
I agree with that. I agree that there's B cells, and if you're going to treat it, you would have to use something to target B cells.
Okay, and then there was a question about the LDH, if that was looked at.
You know, that's a great question, and I didn't think to measure it at that time.
All right, sorry for interrupting.
Oh, that's okay. So because her labs had changed and because she was having dyspnea, but also because I routinely follow lung function tests on my patients, I decided to repeat her full lung function tests. And again, her FEV1, FVC, and her FEV1 to FVC ratio were normal. But this time there started to be some abnormalities. So her area resistance was now markedly elevated at 287% I predicted. And her diffusing capacity had continued to fall and was now 60% of predicted, whereas before it was about in the I think it was 70%. So that was a concerning change for me. So I decided to repeat her CT scan, and at this point, the radiologist read it as an increase in multiple scattered bilateral nodules, mild bronchiectasis, ground glass opacities, an interval increase in the interlobular septal thickening, and like Dr. Rita said, predominantly in the lower lobes, increase in multi-station mediastinal, hilar, and right axillary lymph nodes, and now, for those of you who can see the image, some pretty marked hepatosplenomegaly. So at that point, I decided that this seemed like a case of GLILD, and I wanted to treat. So I did the protocol that Dr. Rudis's group has published with rituximab, 375 mg per meter squared per week for 4 weeks with repeat cycles every 6 months for 18 months, and then mycophenolate 1 gram POBID up to IVIG with a goal of a trough level of 850 at the minimum given her lung disease.
Was there any thought of trying a higher, to get a higher trough level, like going closer to 1,000 at this point, or?
You know, I haven't on my IVIG patients, you know, on my sub-Q patients, I tend to aim for 1,000, but on IV, I usually aim for 850, but I know there's publications out there arguing for even higher. So I did that for 18 months, and she did great with the therapy. In fact, she was so happy that she had done so well that she told me she had lost nearly 50 pounds over the course of her last 18 months. What she told me was because she had been exercising a lot and watching her diet. Thankfully, she didn't have any B symptoms of night sweats, bone pain, or fatigue. But on her CBC, she now had persistent leukopenia, which was modest, a white count of 3.28, normal hemoglobin hematocrit, normal platelets now of 203. Her ALC is down to 600, and she now has 300 atypical lymphocytes, which is about 9.2%. Her metabolic panel is normal. Her IgG trough had just squeaked in above my goal at 866, and this was actually just 2 weeks ago that I saw her, and her genetic testing was sent and is pending. So that's where we are with this patient, and so obviously a little concerning because most people can't lose 50 pounds, even when they're trying really hard. And now she has this atypical lymphocytosis, which makes me wonder, did I do enough to diagnose this? Did I miss something in the workup? And just to prove that the treatment worked, though, her area resistance is now down. Her gas diffusing capacity is now up to 83%. Her FEV1 and FVC remain normal. And her CT is clear with only mild residual ground glass opacities. The nodes are almost gone, and the splenomegaly and hepatomegaly are gone. So that was where I was. I had some questions about the management, which hopefully the group and Dr. Rudis and Dr. Tazelaar can weigh in on the end, but I think Edith, do you want to go to Dr. Tazelaar's presentation before we tackle those questions, or?
Sure. In the meantime, we do have a couple more questions. So it's a question of sort of wondering why no biopsy prior to starting treatment.
Yeah, so she flat out would not go through another open lung would not go through another bronchoscopy and BAL, and had always declined an open lung biopsy. So I was sort of at a position where I didn't have an option to biopsy, although I maybe could have pressed the issue.
Were you concerned that possibly this could be a lymphoma or, CVID that also had lymphoma?
Well, I am now. Hindsight is always 20/20, and hence the discussion for today. So, is a one of the questions I think we can ask the audience and Dr. Rudis and Tazelaar later is, was that transbronchial biopsy I did earlier enough?
Okay, and then Dr. Tazelaar actually has asking how large the pulmonary nodules were.
So the radiologist
it just looked like one of those looked a little bit larger than sort of most of them, although now you're showing us a CT that looks like they've resolved sort of. But I wondered if, at what point you worry more about lymphoma in some of these nodules.
Yeah, I'm here. Yeah, I am now worried about this lady.
And Also, in addition to the worries about lymphoma, did you check viral titers, EBV, CMV, given or also HIV, given the lymphadenopathy and the hepatosplenomegaly?
Yes, so I did check EBV and CMV, and I even went as far as checking HHV6 PCRs, and those were all negative. I don't think I checked an HIV, to be honest, but I might have. I just can't remember.
And then just a general question. I know sometimes that increased IgM goes along with having ILD, but obviously not always. But any thoughts on looking at high IgM versus low IgM in patients that are looking like ILD? I guess that's a general question for...
Yeah, maybe Dr. Rudis has more expertise in that than I do.
Are you talking about, GLILD or ILD in general, or?
I was talking about ILD in general, but also GLILD. So if it means, there have been some papers that have indicated high IgM is associated with CVID lung disease versus perhaps, that might be an indicator. In this patient, the IgM was not high, but just if that's any indication at all of how you're looking at things.
I don't personally use it. And then when you just look at ILD in general, it's just so broad that I don't think it'd be useful either in those circumstances. But I don't think IgM is helpful.
Okay. And then we have a question. If we assume the patient doesn't improve with rituximab, would you consider a bone marrow transplant in a patient with CVID and GLILD?
Go ahead, Dr. Rudis. Yeah.
The question is, the answer is yes. I know that I reviewed a case for an insurance company at Troy's that we recommended a bone marrow transplant, but you've got to factor in some considerations like, where the lung function is at the time. I would say in general, when we have biopsy-proven GLILD and treat them early, we get a good response. The problem happens when it's a late diagnosis and there's, significant fibrosis. Then we recently had one patient go to lung transplantation. So, that's a big problem. But it could be considered. But as you know, there's only one paper with a large cohort of bone marrow transplant and CVID, and it didn't look all that great.
Yeah.
Okay. Well, I was going to say, I think we, if you're ready, I think we could move to Dr. Tazelaar's presentation.
Yep.
All right, I'll advance it here. So you all know this better than I do. I am a pulmonary pathologist, but this forms a small part of our practice. CVID, as you know, most often is going to be the lung is going to be involved by infection. Obviously, bronchiectasis is a key feature, and this patient had that. Many of the patients have asthma, and then really what we kind of wanted to discuss tonight was the quote interstitial lung disease that these patients get. And, the term GLILD has been applied to this, although I think from a pathologist standpoint, it's maybe not as aptly named as it could have been. Many of these cases also have organizing pneumonia with or without, granulomatous disease in the background. So when you look at the pathology under the microscope, in cases of patients with CVID and have so-called GLILD, they have a variety of histologic findings. Rarely they can have something that you would call, as a pathologist, again, lymphocytic interstitial pneumonia or LIP. There's a couple of variants of that, and I'll show you a couple in just a moment. Many of the patients have non-necrotizing granulomas, but not all of them, hence a little bit of a problem with the term GLILD. Follicular bronchiolitis is a prominent feature, and rather than most of the patients, and we just reviewed about 20 patients in our consult practice here at Rochester, as well as from UBC, most of them looked more like a diffuse lymphoid hyperplasia than anything that looks like an interstitial lung disease. It is more nodular, I think, as has been mentioned. Many of them also have prominent organizing pneumonia, and then probably as a result of repeated infections, again, as has been mentioned, they can have fibrosis, including honeycomb change, although this does not look at all like UIP-IPF, which is the typical place where we talk about honeycomb change. So here's an example that I would call diffuse micronodular lymphoid hyperplasia. It's not really an interstitial lung disease, if you will. The lymphocytes are in the interstitium, but there's a lot of the interstitium here that's relatively normal. There's a little bit of emphysematous change up here, probably due to scarring. Can everybody see the arrow?
I don't know that everyone can see the arrow.
All right, well, I won't worry about the arrow. I'll just talk to where things are. So in the upper left, there's some enlarged spaces. It looks a bit emphysematous. Most of the rest of those, the blue there is all lymphoid aggregates and lymphoid follicles. Here's a little higher power. And here's over on the right at about 3 o'clock, that larger nodule, which is probably about 4 millimeters maybe, is a little focus of organizing pneumonia. And we'll look at that on a little higher power. It's actually got some vague granulomatous features. So that oval is around a giant cell. The pinkish cells are all macrophages. There's other giant cells in and amongst that lymphoid tissue. And the background there is that of an organizing pneumonia. Here's another aggregate of histiocytes forming an ill-defined granuloma in one of these lymphoid aggregates. So there's sort of a spectrum of what the granulomas look like as well. Here's another case, and again, it emphasizes the nodular nature of this rather than the interstitial nature, if you will. On higher power, you can see the bronchovascular bundle right in the middle at about, say, between 5 and 6 o'clock. There's a bronchiole there. And then sort of going from, say, 11 o'clock all the way around back up to, maybe 1 o'clock, it looks like there's probably a vein or an interlobular septum that's tracking. And some of these nodules are tracking along the septum as well as following the bronchovascular bundles. And again, notice that the surrounding lung, if you talk about this as an interstitial lung disease, is really pretty normal. Here's an area that you can see the blue around the edge, which is the lymphoid hyperplasia. And then we have more foci of organizing pneumonia, which are those small polypoid plugs that have the arrows on them. Those are the classic Messon bodies, or the classic areas of Boop, if you will. This case, the cases that I showed you were not particularly worrisome for lymphoma, but we could certainly work these cases up for lymphoma, particularly when they get larger nodules and the nodules seem to become more confluent. CD5 we would do to make sure that there's no co-expression on the B cells, which there doesn't appear to be, so that helps exclude CLL. The most common would be a MALT lymphoma in this setting as well, but CD5 generally is going to be negative in that. CD43 can also be positive on the B cells, and that would be an indicator of malignancy, and this sort of mimics the CD3 above it. The CD20 highlights the fact that the B cells in some of these cases, in this case that's benign, you don't see B cells in between the follicles. That's why we're doing this. We want they're scattered in between, but you don't really see a sheet of B cells, which is what you would expect for lymphoma. CD138 stains plasma cells, And as you can see, there's very few of them. Some cases have virtually no plasma cells, but we've certainly seen some cases where plasma cells are present. Kappa and lambda just showing that there's a few plasma cells there by Kappa and lambda light chains. There clearly is not evidence of clonality, so at least in here, no evidence of lymphoma. So there's a wide spectrum of histologies. In these cases that we just reviewed, in fact, some cases look very much like sarcoid. I did not have an opportunity to get any of those photographed for this, but some look a lot like sarcoid. I think maybe this is a useful clinical term, but the average pathologist is not going to know what to do with this description of GLILD without really digging into the literature. It is more nodular, and then granulomas don't exclude lymphoma. I won't read all that stuff because we just talked about that, but granulomas don't exclude lymphoma. 20% of all lymphomas, for example, can have granulomas. Just to round out the discussion, one of the reasons a group of us got together to sort of look at these cases was we wanted to understand how different these were from what we would call LIP. So LIP, the patients also have signs of an ILD. Under the microscope, even LIP is a very heterogeneous group of pathologies. There's diffuse nodular lymphoid hyperplasia, in which case I might say some of the cases of GLILD look a lot like LIP, and I don't know why we created a new term. Some patients have diffuse interstitial lymphoid infiltrates. Other patients have follicular bronchiolitis, and there can be variations and combinations of all of these. And in straightforward LIP, giant cells and granulomas are present in greater than 50% of the cases. So here's an LIP diffuse lymphoid hyperplasia. Again, looking not too dissimilar from what we just looked at. Maybe the germinal centers here are a little more prominent, but that's going to be variable in cases of GLILD. Here's a case that I would think looks like a classic LIP. It's diffuse, it's interstitial. You can see the inflammatory infiltrates there on high power include some plasma cells. That would be a classic LIP that you might see in someone with a CTD. The other form of LIP, and this is more of a radiology diagnosis, is this cystic pattern of LIP. So upper lobe predominant, cystic lung disease. The radiologist will often call that LIP or consistent with LIP. There's a differential. And again, this does not look very interstitial for a pathologist. There's nodular aggregates of lymphocytes, sometimes with follicular bronchiolitis, and then these enlarged spaces. So I think some of the stuff, so anyway, I'll turn this back over to, I think, Monica or Dr. Schussler.
I think Dr. Schussler was going to kind of go through the discussion.
Yes, and this is a great place to start. And one of the comments that came in while we were going through this was really the question of whether it's or basically asking that if a lung biopsy just is part of the workup and you need to do it as many of the guidelines say, or is there a point at which it becomes absolutely necessary? Should it be done from the very beginning when you see the CT, or when is the right time? Because as Monica said, patients are not really looking forward to having an open lung biopsy. It's a difficult idea for them. So sort of as a first discussion point, when do you decide to do that? How do you decide? Or is it just absolutely you must upfront do it?
I'm the pathologist talking, but and then others can jump in. But it seems to me when you're at a suspicion that you're dealing with lymphoma because the size of the nodules, they're becoming more tumefactive and maybe distorting underlying architecture. I mean, it's sort of almost a radiologic call to my way of thinking. Sorry about that. To my way of thinking. But you're not going to get much on a transbronch. You might get chronic inflammatory cells like we did in this case. you could ask the pathologist to look for plasma cells, and if you don't find any, maybe that's a soft criterion, but it really depends on how big the biopsy is. So, I mean, if you're going to do anything, I think you need to do a biopsy big enough to work it up for lymphoma, and it's going to be an unusual transbronch on which you're going to be able to do that, maybe on a cryo.
So I'll second that. We are going to start doing cryos to see if that will help, but we do VATS in all of the cases. Just a couple comments on, there are some, I'm not a pathologist, so I think we need to have all the pathologists and the clinicians get together and talk about the pathology here. But initially, when we described GLILD, it was Carleen Kuhl, who's a pulmonary pathologist at National Jewish. It really was the one that described the major features, and then Arjun Rao, when I'm now at MCW, found that sort of the same thing, that you see this pattern if you do enough cuts of granuloma, follicular bronchiolitis, and LIP. And again, I trust me, I believe, your pulmonary pathologist, that's all you look at. It's just when I'm looking at the table on our paper, they do describe a fair amount of interstitial inflammation, and certainly we saw fibrosis that isn't like UIP. It truly is not, in about 40% of the patients. I think that most common diagnosis that's confused with GLILD is sarcoid, and I think under that circumstance, you have to take the entire patient into account. Sarcoid does not look the same radiographically as GLILD. Sarcoid is almost always upper lobe predominant, not always, but almost always. It tends to be micronodular, and you don't get diffuse adenopathy, you get those huge lymph nodes typically in sarcoid. Sarcoid tends not to have other features that are typical of CVID and GLILD, like autoimmunity. Splenomegaly can occur, but it's usually not a prominent feature. Bronchiectasis typically is present in CVID, and in particular in GLILD, usually not a prominent feature in sarcoid. And obviously there tend to be hypergammaglobulinic versus hypo. And so I think that with the radiographs, that if you work with the pathologist, and look at the radiologist, it's clearly a different disease. And so my feeling about this whole thing is that the lung just reacts to immune dysregulation and sort of in Th1-driven inflammation in certain sort of genetically predetermined manner. And you get LIP, you get follicular bronchiolitis, you get tons of organizing pneumonia. One of the first cases I saw when I was at MCW was, referral from Pulmonary, who they did a transbronchial biopsy, and it was called cryptogenic organizing pneumonia, and the patient was on high doses of steroids for 6 months and had no response. So another reason, apart from, excluding lymphoma, is the idea that you can get, a biopsy artifact, depending on, as was pointed out, the pathology here is quite diverse. You have large areas of bronchiolitis, obliterans, and so I'd leave it there.
Jack, thank you. What do we think? What do you think the organizing pneumonia component is due to? Do we think that's sort of the slowly resolving infection that's passed, or we were struck by the number of the prominence of the organizing pneumonia in the case that I looked at from Roshini about a month and a half ago. That kind of got this whole conversation started and got me involved tonight. Had a lot of organizing pneumonia, and at that point I was very concerned about infection, but then the more we looked at these 20 cases, it's really a prominent feature.
It really is a prominent feature. In about Just looking at this table. It's at least moderate to severe in 50-60% of the patients, and it's present in almost everyone if you make enough cuts. Sorry, our dogs are going crazy. So I don't know. We're always very careful because I'm just uncomfortable starting someone on 18 months of immunosuppression unless I really am, pretty sure of the diagnosis. And so we always do BALs and, for everything, including CMV and things like that. And then we do PCR in the blood for EBV, CMV, and HIV-1. But, it's rare for us to find anything on BAL. And so I don't know. It's a great question why you see so much organizing pneumonia. It's just weird.
I mean, OP also occurs in other, this is not a CTD, but it, occur in CTDs, yes. And we assume it has some some immune dysregulation. So maybe it really is just part of that in this group of patients.
So, sort of moving from that subject, but related, looking at treatments, starting with rituximab, going back to if you're going to use rituximab and there's, it doesn't look like lymphoma on the CT, when do you, because you're going to be treating it to some degree and it may respond to the rituximab to some degree, how do you know that it's okay to use the rituximab at that point?
In general, again, this is just my experience. In general, although I've been fooled, a couple times, when it's a high-grade lymphoma. We've seen, several MALTs in this group of patients. But I doubt this patient. Now that you've got all these other atypical findings on this patient, I think you're pretty much, you pretty much have to work it up. You might consider a PET scan and a bone marrow and the usual stuff that oncology would do. But, usually when you see a high-grade lymphoma and CVID, you know it. Although I admit with GLILD you can get confused because a lot of these patients have grade B symptoms.
And then on the treatment question, it seems the rituximab is primary from, or at least highly recommended. But what about other agents like azathioprine, cyclosporin, mycophenolate mofetil, just basically your experience with that, or infliximab, when and what would determine if you'd use any of the other agents?
Well, I can just tell you before I came up with that combination, starting at National Jewish, I tried. I was involved and worked with people in the interstitial lung disease group. At that time, azathioprine was used for interstitial lung disease, although it didn't do anything along with steroids. We tried that. It didn't work. I've tried single agents. They haven't worked. I've tried Rituxan. Rituxan will work some by itself, but you don't see that, complete remission. And then I guess the question is, for the other stuff, because there's reasonable data that, things like TNF blockers look like they have some effect, and in patients that have LRBA or CTLA-4 haploinsufficiency, it looks like abatacept has some effect. But I think the advantage of doing this is, at least initially, you give them 18 months and they're off. Some stay in remission for quite some time, some relapse. We're in the process, hopefully, of getting this paper out pretty soon on about 40 patients. But, and so, and we find that this works, mycophenolate or azathioprine and Rituxan, regardless if it's monogenic. So, anything from CTLA-4 to NF-kappa B, we've had XIP. It doesn't seem to matter what the monogenic disorder is. The response is, in general, unless there's a lot of fibrosis, it's like what you experienced. It's uniformly really quite nice.
And then I guess maybe a last question because we're coming towards the end. When do you decide to treat? So is it as soon as you see anything, or is it when you see decline in function? When is the best time to intervene with the treatment?
Yeah, it's easy for me to say, but, when you look at the CT scan, when it's time to treat. We always put them on IVIG first with the off chance that a lot of this is inflammatory. But when you see this large nodular disease that, isn't going away and typically slowly gets worse, and it's significant. It's not just a few nodules. If it's a few nodules, we'll re-image in a year and say, okay, what's going on? But and that's sort of the biggest thing. I believe, when we looked at fibrosis, now we're a referral center for this, so we get cases that are probably delayed, but 40 to 50% of our patients had moderate to severe fibrosis. And so I really do, part of the debate in the literature is, what does this disease do? Does it cause progressive pulmonary fibrosis? And, unfortunately, we don't have a double-blind placebo-controlled trial to look at that. But having seen these patients over the last 20 years, I'm a firm believer that it causes fibrosis like all inflammatory lung disease eventually will. It's not UIP. It won't kill you right away. It's indolent and slowly progressive. And I would say you have to have significant infiltrates. And I wouldn't use PFTs necessarily as a decision maker because like DLCO is incredibly insensitive for picking up a diffusion block, even in the context of ILD. So it's an ancillary thing. It's something that helps it if it's down, but we usually take it all into account. CT scan, how severe the disease is, PFTs, how the patient's feeling, and then make a decision.
So I'm going to ask the audience. I think there are no more questions at this point, and that was a really great discussion. Monica, did you have anything to add at the end?
Nope. I will keep you guys posted on what we find out with this patient. But I appreciate all the input from everyone.
Okay. Well, I'd like to thank you all for participating tonight. I think that was a great discussion, and hopefully everyone will join us again for the next webinar.
Thanks.
Okay, thanks.
Thank you.
All right. Good night.
Good night.